Welcome back, you guys, after lunch. And we kind of waited a little bit to start because we heard word on the street was that some people needed vitamin D and they were maybe out by the pool. But thank you. That was a nice round of applause you gave this panel, because this is a great panel. And we were back having a great conversation backstage, and so I know that we're going to continue that here. And there is going to be a question and answer after this, so please don't hesitate to come up with those questions and ask them. But this is the phase 2 of okay, I thought they were making comments about me, and I was going to turn around and find out what it was. I had to do it. But we have a great panel. I'm just going to let them take it away and introduce themselves, and I'll be back in a bit. Thanks so much, you guys.
Hello, can everybody hear me okay? Yes. Okay, lovely. My name's Angeline Edwards. I'm a pediatric urologist at the University of Iowa in Iowa City. I am from Kentucky, so I have a little bit of an accent. And so I'd like to just talk to you today a little bit about urology and maybe some of the concerns that can come up for somebody with Duchenne's muscular dystrophy. And most commonly, some of the concerns that, or maybe reasons you would seek care from a urologist would be incontinence, meaning leaking urine day or night, urinary retention or inability to empty the bladder, urinary frequency, urgency, or that feeling of I gotta go right now, urinary tract infections, or kidney stone formation. And so this is a study done by some of my partners and Dr. Matthews at the University of Iowa prior to me becoming faculty there. And they just surveyed or went through patients' charts. They had 135 patients with Duchenne's muscular dystrophy and saw why did they see a urologist or why did they have a urinary diagnosis in their chart. And as you can see, over 50% of that 135 young men had a urinary complaint. And most of them surrounded urination, so voiding symptoms. Enuresis or wetting was the other. Some of the other common things that came up were kidney stones, undescended testis, which is what Crip organism is, blood in the urine, or urinary tract infections. And so one of the things I'd like to bring up is maybe urinary findings happen more often for patients once they have progression of their disease. So patients that are non-ambulatory have a diagnosis of scoliosis or history of spinal surgery. So sometimes operating on the spine or having scoliosis, especially if it's severe, can cause some trouble with bladder emptying. And then needing invasive respiratory support was also a risk factor for having urinary symptoms. And so this is another survey done. This is a Dutch study, and they surveyed 199 young men with Duchenne's muscular dystrophy, and 85% of them stated they had a lower urinary tract symptom. So that can be frequency, urgency, urinary leakage, feeling that they can't empty their bladder or straining to urinate. What was most common in the children that are 4 to 5 years old, so this preschool age children, was decreased bladder sensation, the need to urinate at night, or urinary incontinence. In older adult men, the straining or feeling of incomplete bladder emptying, or feeling like they have a slow urinary stream. And so one of the things I'd like to let you know is we're here. And so this is something we talk to people very commonly about, and we're a very safe space to talk about urination, stooling, sexual health, any of those concerns. We're the right doctor for that. And so as life expectancy continues to increase, there's a lot that a urologist can offer and bring, hopefully, to really improve the quality of life. So myself as a pediatric urologist, I tend to focus mostly on toilet training, helping kids with urinary accidents, bedwetting, and then toileting independence and what that looks like. Sometimes it's just troubleshooting how to help a patient undress themselves and use their urinal efficiently, or what they're comfortable with getting assistance with. And so what are some of the reasons we may, somebody with Duchenne's muscular dystrophy may have lower urinary tract symptoms? Some of it may be just related to delayed toilet training or learning difficulties. Sometimes it has something to do with waiting too long to use the restroom. It's very common for children to want to hold urine and stool because they feel more comfortable at home or with their caregiver to use the restroom. Sometimes it's functional. They just can't transfer on their own, or someone was not available to assist. And other things may be happening in the background to their bladder muscle, the external urinary sphincter, or the central nervous system. And so this is another study that I thought was really nice to see. So there is something called bladder bowel dysfunction. That's an umbrella medical term, if you will, for any lower urinary tract symptoms when we talk about it in the space of children. And so they had 57 patients with Duchenne's muscular dystrophy, and they had 56 healthy controls. So they just did surveys on boys the same age that were coming into the doctor's office for sports physicals, those types of things. And so in this, 74% of the Duchenne's boys expressed a concern for at least one lower urinary tract symptom, and 56% of the healthy controls also had a symptom. But I'd like to point out, and I think Dr. Williams has already started to draw a lot of attention to this, but the Duchenne's muscular dystrophy patients, 68% of them had a bowel symptom in comparison to only 40% of the healthy controls. And then when you put those in combination, they can add up and kind of worsen the urinary health or the symptoms someone may experience. And so what is bladder bowel dysfunction? So it is dysfunction of the lower urinary tract. It can be feeling like you've got to go to the bathroom, you've got to go right now, wetting during the day or night, pain with peeing, feeling like you can't get your urine out, straining to defecate. Those all fall into that, diagnosis of bladder bowel dysfunction. And so, sorry, I wanted to be able to use a pointer to point to the bladder here. But on the first picture, this is just a cartoon we use at the University of Iowa to help kind of talk about bladder function with children. And so the very first picture is our normal bladder. So the bladder wall should be nice and relaxed when we're filling with urine. And the red at the bottom is the external urinary sphincter or pelvic floor, and that should squeeze tight so we don't leak urine when we don't want to use the restroom. And then our next picture is what should happen when we urinate. So our external urinary sphincter should totally relax, and then the bladder should be giving a nice squeeze at that time and allow us to completely empty our bladder. Well, sometimes those things don't all happen together and as coordinated as they should be. Sometimes the pelvic muscles are squeezing at the same time the bladder is squeezing. And this can happen in healthy children. And so this can be a concern for children of all ages, but we may see that this problem more often in Duchenne's muscular dystrophy because they have comorbid constipation or holding. And so this is another cartoon we use very commonly to kind of discuss this. So sorry about the angry poop, but it really helps at least give a visual to kind of what can be going on. So if we have a large stool burden in the rectum, it can be pressing on the bladder and causing irritability and having little squeezes or little leakage of urine. And it can also impact bladder emptying. So I've definitely probably once every other call take care of a child that has urinary retention just from constipation. So no neurologic cause, just because they have such significant constipation. And so what's our first management strategy? And it's actually behavioral modification. So there's a lot we can do with changing someone's behaviors. And the first is I work with the family and with the child to find out what is their pattern and what are they doing at school. And then from that, a lot of times I'll talk with their teacher, send a letter, we'll use their iWatch as a reminder, or get them on a time toileting schedule with the school nurse where they're using the bathroom every 2 to 3 hours. That's when children should urinate. It is, in our American culture, we like to hold a lot longer than that, and it's not a healthy habit. And so using and cycling the detrusor, the bladder muscle, more often is gonna improve continence, and it's also gonna preserve the muscle function of the bladder. And so waiting too long or waiting for the sensation to urinate, if you've stretched your bladder over time, that can lead to urinary accidents. So going to the bathroom on a schedule would be the first step. The next is appropriate hydration, and this is super important. And a lot of times kids are smart, so they'll back down on drinking liquid if they know they don't want to have to use the restroom. But a lot of times that can become a vicious cycle that we get stuck in because it also, if we're not drinking enough or underhydrated, that can cause constipation. And so those things kind of can continue to rope into each other. And so just one of these quick and easy ways to remember how much water we should drink, I usually suggest we drink half of our weight in pounds. So if you're 100 pounds, drinking 50 ounces of water a day would be a good amount of intake, and avoiding caffeine. A lot of times I get on a water bottle and toileting schedule through a school nurse or in somebody's IEP with them. So I make sure that their child, while they're away from their caregiver, they're drinking the amount of water they need and they're getting their scheduled toileting assistance. And so one of the other important things is toileting posture, so feeling well supported. So having a stool under the feet, having rails in your restroom at home or at school that can help feel stable on the toilet, so you're not activating the pelvic floor muscles while you're trying to urinate or have a bowel movement, is really important. And most children can't reach the floor to support while on the toilet, and so having a stool is really important. And last is making sure you're having a daily soft bowel movement. So Dr. Williams did a great job earlier of already saying this, but this is a huge part of what I do as a urologist, is I spend a lot of time making sure that children really have a great bowel program that works for them, that have bowel movements that they know when they're coming, and that they're dry of stool, because that usually will help me get urinary dryness. And so importantly, I need to figure out why the patient is having symptoms, because just because we have muscular dystrophy, that everybody may have symptoms for a different reason. And so they may have functional incontinence, difficulty transferring, urgency, they may have just started steroids or have polyuria, making too much urine, or they may have constipation. And so these would be all things that we can figure out. There's some non-invasive options we can do, such as doing a bladder diary. So your doctor may ask you to use a urinal for a 24-hour period and write down what you're drinking and what time you urinate and how much pee. So we know what your kidneys are doing and how we can improve your program. Sometimes we ask you that we could do something called Uroflow. That's, I've had multiple of my patients call it the magic toilet in our office. It's a, no funny, it's a toilet that just has a sensor in the bottom of it. And so when the child urinates, we can tell what pressure they generate. And then we can put a little ultrasound over the tummy and see how much is left in the bladder after they urinate. So that gives us some idea of how well the patient's emptying without talking about catheterization. And then lastly, we have some more invasive testing called urodynamics. And this is just a quick talk about this. There's a small catheter we can put into the bladder and a small catheter in boys that would go in the rectum. And it tells us as the bladder's filling, does the patient hold the expected amount? And is the bladder muscle quiet while we're filling? And then does it generate a good squeeze and empty completely? And then are they storing their urine at a safe pressure for their kidneys? And so there has been a few small case series published for muscular dystrophy. And in this, there was a group of 9 patients, aged 7 to 14, that had that catheter test, the urodynamics test. And in that, 8 of the 9 boys had bladder overactivity. So they were having bladder squeezes prior to the actual being allowed to urinate, if you will, or the sensation to urinate. And of those, 7 of them had a small capacity bladder for age, so we can estimate how much somebody should hold for their age. And then there was 1 patient that did have overactivity and the incomplete emptying, but they had had spinal surgery, so it was a little bit difficult to tell if it was potentially related to spinal surgery. But in this study, they gave all the patients with overactivity a medication that addresses bladder overactivity called oxybutynin, and all of them improved. So I think that is something really positive that was published in that study. In older case series, so 6 men older, average age around 25, had normal bladder capacity. 1 had overactivity, but 3 had what we call detrusor sphincter dyssynergia, where that means the bladder muscle is squeezing and the pelvic muscles are squeezing. And so that can sometimes generate elevated bladder pressures or incomplete bladder emptying. And so what are some of the things we can offer? If somebody has overactivity or a small capacity bladder, we could offer medications. A lot of these medications are anticholinergic medications, so it just depends on what other meds people are on. We have to talk about risks and benefits. We do have one that's Merbegron, that's the commercial where the little bladder follows the lady around, but it works by a different mechanism, beta-3 agonist, and it doesn't have a significant side effect of constipation or dry mouth like the other classes of medications. Sometimes we just need to work on strategies to make peeing easier. So finding if a patient as they get older may want to use a condom catheter or need to troubleshoot the urinal they're using. And then briefly, I wanted to just touch on for just a few moments what we do potentially for patients with more progressive disease or have incomplete bladder emptying or urinary retention. And so there's a lot of good options we can offer. One is clean intermittent catheterization. That's where the patient would catheterize themselves through the urethra with a catheter. They put a catheter in and drain their bladder, and then they remove that catheter, but then they're able to have control when they urinate, if you will, but they have to have enough hand dexterity to be able to do that for themselves. This is something that's a great option because it still allows sexual function. There's nothing that's indwelling through the penis for our adult patients, and if they do need this to drain their bladder to keep their kidneys healthy. It has a lower risk of urinary tract infection than the indwelling tubes, such as wearing a catheter through the urethra. That one most urologists would discourage unless we're right at the end of life because we can get urethral erosions, urinary tract infections. It's uncomfortable to have something through the genitals all the time. And then the other would be a suprapubic tube placement. And so I think a lot of times we think this has to be done under general anesthesia. I will tell you that most urologists can do this in somebody that has not had abdominal surgery under local anesthetic. So we can numb up the skin and place the suprapubic tube, which goes in between the belly button and the pubic bone directly into the bladder. And much like the gastrostomy tube that was talked about earlier, this is an option. If you don't like it, we can just deflate the balloon and remove it. So it's definitely not a permanent, but if you're unable to empty your bladder or you want a way to be constantly emptying, if you will, but not in a diaper, a suprapubic tube is a way to do that. Sometimes there's some in-between options. So this is actually a picture of somebody that has a suprapubic tube tract, but they have a gastrostomy button in it. So much like the gastrostomy feeding tubes, we can put those in the bladder, and you can hook to a drainage bag every 3 to 4 hours and empty your bladder and then plug back, so that would allow somebody to empty their bladder, to not have to transfer or place anything into the genitalia, but to be dry in between. And lastly, this is coming from our experience with patients with neurogenic bladder, would be a catheterizable channel. So I know it was briefly mentioned earlier, a Mitrofanoff or Monty, or sometimes it's called an appendicovesicostomy, but this is something we do very commonly in the spina bifida population or tethered spinal cord for patients to be independent and drain their bladders. And so this is taking the appendix, sewing it from the belly button to the bladder, so that way somebody would be able to put a catheter in and drain their bladder, but the genitals are not being seen by a caregiver or a nurse at school, and they're able to completely empty the urinary system. So that's something that's very popular for patients with spina bifida. And so in conclusion, I just want everybody to know that there's a lot we can offer, and it seems like there's a need, and that we should be a doctor that we can drastically, hopefully, improve the quality of life that somebody has, and that dryness is different for everybody at different points in their life. And so there's a lot of things we can offer. And then lastly, I just wanted to let you all know I am currently doing a research study for toilet training in boys with Duchenne's muscular dystrophy. So if you have any interest at all of participating, that would be lovely, because I was asked by a few moms at a talk I gave in the fall, and there's not a good paper put out about the toilet training experience. And so this is a de-identified survey through the University of Iowa, so hopefully we can give some good information back about the experience of toilet training.
Hi everyone, I'm Dr. Kendan Fawcett, and I have a PhD in behavioral health science, and I am a registered and licensed dietitian. I am actually coming to you from Central Arkansas because the weather was not cooperating, and they say question Mother Nature and she will give you something for an answer. So I changed my background filter so I feel like I am there with you in California. Not quite as much fun, but it's the best we can do. So I'm going to start to share my screen. And I want to talk to you a little bit about why I believe nutrition is so important in this community. Like I said, I'm Dr. Fawcett. Some of you may know me from clinic. Some of you may know me from different Facebook groups. And today I'm here with a couple of different hats on. So here's the bio. We'll tell you everything you need to know. Basically, the one driving factor that makes me so excited to talk about things, knowledgeable, and trustworthy is this. I have a 13-year-old son, Tyler, who has DMD. Tyler has been in a power wheelchair since he was about 9, and he is actually on his second one right now. So as you can see, Tyler has a lot of activities with a lot of people, and he's a super, super kid. But just like all of our kids, we sometimes don't notice some of the things that start to happen. So Tyler started to gain a little weight after, and I bet you all can think of the issues in your head. Started steroids, quit walking, and his little body was not doing the amount of exercise or work that it would have before. So this is where we kind of started our journey in nutrition. So I'm going to present this cycle, but it also does not have to be cycle bound. It can be something happened, then something else happened, then something else. So as I go through this, I just want you to have an idea of what that looks like. And then also, I'm sure Carrie will send out notes. You can always contact me. I have my information at the end of the slideshow. So the first thing I want to talk about is preserving lean muscle mass. So this is going to be very important at the beginning of this disease and diagnosis. Let's keep our boys as healthy as we can for as long as we can. So to preserve lean muscle tissue, we are going to focus on eating healthy, lean proteins, such as fish, lean meats, chicken, looking at vegetarian options such as tofu, also looking at eggs, calcium, dairy, basically foods that are going to keep us feeling full longer. And that's called the satiety factor. Secondly, we really want to prevent excess fat buildup. So this happens from the front end. Instead of getting to the point where we are trying to lose weight, we want to keep and start a path where everybody maintains and gains weight according to guidelines. Some of the things that can help us prevent excess fat buildup is going to be to look at foods that are whole, real, things that you can pick off a tree, grab, out of the fridge, like an apple, banana, orange, animals that you might see. So beef, my dad was a cattle rancher, so we ate a lot of beef growing up, and things that are what I would consider whole foods or real foods. Thirdly, we're going to want to prevent weight gain. So by following these first two, we're already on our way to be very successful. So to prevent weight gain, we certainly want to watch portion control. And I just happen to have some pretty cool little visual aids that I like to use. Now I have a son, Stone, who's almost 4, and he doesn't believe that these are mine. He believes that they are his and they go in the bathtub. But he's not here, so I was able to take him back for a minute. But you'll see that I have them labeled. So we have a cup all the way down to a half of a tablespoon. So we've got a couple in there. These are just very generic measuring cups, but it'll give you an idea of what portion size looks like when you start your journey. And I have a label maker, so I got to label them, which if you're anything like me, you geek out on stuff like that. Fourth, we want to prevent fractures, issues with our bones, breaks, things of that nature. So we want to keep our bones strong. To do this, we need calcium and vitamin D. And also, we really would like to see those minerals and vitamins coming from food. So the importance of eating healthy and eating whole foods, real foods, is going to be key here. We also want to prevent insulin resistance. So we want to keep our levels steady and low. So things that we want to eat when we are trying to do this are whole grains, whole fruit, eat the peelings. That comes in a little bit later with fiber, and making sure that we are eating regular meals at regular timing, and they're portion controlled, as well as providing that satiety factor. So think of a cheese stick and a piece of fruit. Think of a whole grain piece of toast with avocado or a nut butter. We also want to maintain normal cholesterol and lipid values. So here, we want to make sure that we're getting labs frequently and we're monitoring that. So to prevent some of those high lipid levels and cholesterol levels, we have to watch what kind of foods we eat. So a good rule of thumb is stay away from boxed bag foods. Secondly, if you can't pronounce the ingredients in the ingredient list on the box, on the bag, whatever it is, might not be the best choice. We really want to focus on at least the first 4 ingredients, things that we know. And then also preventing constipation. This is one of the other goals that has been set for this population. To prevent constipation, we most certainly need to drink water, which can be an issue in itself with this population. Think about it. The more you drink, the more you have to use the restroom. And if you're dependent on somebody else helping you use the restroom, that can be pretty hard, especially if you're a boy at a certain age, mid-teens, even younger adolescents. It's hard to ask other people that are not your primary caregivers to help you out. So we have to think creatively and strategically on how to get that water to these boys and how to make them as comfortable and as happy as we can. So what should I expect at a nutrition visit? Let's say you come into clinic and you see me and you're like, oh, it's Dr. Fawcett, how fun. Or you might be like, oh, it's Dr. Fawcett, yay. Either way, I'm here, I can take it. But we're gonna look at 4 big areas. We're gonna look at dysphagia, constipation, reflux, and gastroparesis. So we want to make sure everything is working well. So from input to output, are you able to chew? Are you able to swallow? Are you able to eat your food and not have really bad heartburn? What does that look like for you? What does your mealtime look like? And see if we can correlate any of that with any symptoms you may have. Also, we're going to do weight, height, and caloric needs. Now, this is not a judgment. This is not a time for you to feel that we are trying to tell you you can't eat a certain way or can't do things a certain way. We just want baselines because we want to know how our children are growing and maybe we're missing something. Maybe we have a kiddo that really doesn't like a certain food, but that certain food has an essential component that they need in their diet. After we do this, we're probably going to do something that looks like a food diary or a food intake. I'm going to sit there, you'll sit there, your kiddo, your husband, your partner, maybe your dog. We're all just going to have a big conversation about what your food looks like in the house. It, again, is a non-judgment zone. You tell me, the more honest you are, the more real you are with me, the better I can help. And then we always are going to talk about vitamin D and calcium. So are you on a vitamin D supplement? Are you on a calcium supplement? Does your child drink milk? Do they eat cheese? Do they do dairy? So getting all the information so we are best prepared to help these kids. So I'll briefly go over calcium needs. We'll see, adequate intake for a general population is a little bit different than calcium needs for boys and males with steroids. The reason being, steroids are kind of not happy with bones, if you want to call it that. So we need to up that calcium so our bones are stronger, so our bones can kind of fight that and say, hey, look, I'm getting all the calcium I need. I'm doing well. And then we'll talk about nutritional needs. So right here, we're going to talk about macronutrients and then a couple micronutrients, which would be vitamins. But macronutrients are those ones that you think and you hear about all the time: protein, fat, carbohydrates. So protein has 4 kilocalories per gram. And I'm going to look at your child's weight and their height, do some math, and I get an equation and I get a form that says, okay, he needs so many calories. From that, I'm going to start to say, okay, now let's go from here. Recommendations go from 0.85 all the way up to 2. I usually start these boys at 1.5 grams of protein per kilogram of body weight because that is going to give us a higher satiety factor. All that means is it's going to keep them feeling fuller longer. This should be about 10 to 35% of their daily caloric intake. Next, we talk about fats. So fats are really good for our hair, our nails, our skin, but they also can be dangerous if we are not eating the correct kind and the correct amount. So we usually do 30 to 40% of daily caloric intake, and we're really going to try to focus on fats that are healthy fats. Avocados, nut butters, looking at foods that have fat in them, salmon, things of that nature, versus just the fat you get in potato chips. And then carbohydrates. And this is a question I always get. Carbohydrates are not a bad food. There are no bad foods. There are different choices and maybe better options for each individual person, but that is something that we can talk about. If you do not have an allergy or some type of issue or reaction to a certain food, I'm never going to ask you to remove that from your diet wholly. And then fiber. So fiber is going to be the stuff that helps move all the food through our body. And what this is going to do is give us that bulk. So when we do poop, we're not pooping diarrhea. We have a good bowel movement that's going to move things through. Our body's going to keep what we need and get rid of what we don't. A lot of times with constipation, we notice that boys are not getting enough fiber, and that's one of the big issues. Secondly, to that, water. So you should be drinking 1 ounce of water per pound per day. So let's just use a very easy example of 125 pounds person. They should be getting 125 ounces of water a day. This comes up a lot in clinic because these boys are having a hard time drinking water for multiple reasons. It could be they just feel full. It could be they don't want to ask someone to help them use the restroom, especially at school or a party, things of that nature. So when we talk about how much water your child needs, we're going to find out a plan that's going to work best for you. So for instance, if your kiddo doesn't like to drink water during the day, right when they get home, hey, we're going to do a big glass of water before we play our video games, before we have a snack, whatever that may be. And then vitamin D. If you're not on a supplement and your provider hasn't discussed it with you, that's something you might want to bring up. So looking ahead and why nutrition is so important in this field. Number one, this is something you and your family have control over. And a lot of times in this disease process and this thing that we're calling life and everything we're doing, things can get messy and overwhelming, and food is something you know that you can control. You know you can put this in your body and you know what that helps your body do. So with proper nutritional support, mobility and function, and I say this as a may, we don't have enough research and evidence yet to back this up, but we may be able to keep these boys functionally healthier with mobility issues, with support, with function. So it's something that we can do now, and we can do it, just the everyday general population. And if you have questions on nutrition or food, you're thinking, well, eating healthy is so expensive. What do I do? Call me. You can email me. You can get in touch with me, and we'll figure out a plan that works on your budget. And then also education or the family buy-in, because we want to see changes and we want to see these documented changes, because that's going to give us leverage. That's going to give us leverage and help to go to different places, such as academia, such as the government, nonprofits, clinicians even, to advocate for this type of research, translational research, research that we're doing and we're putting it into the hands of the people that need it. You, me, our kiddos. And then lastly, it allows us to have a higher rate of nutritional studies being discussed and thought about and brought up for things like clinical trials, because there are other avenues to complementary ways of looking at this disease and treatment and maintenance. So it is very important for us to advocate for not only ourselves, but our boys, because this is something that can really make a difference. So if you want to connect with me, here is my information. That's my website. And then that is my email. That is my phone number. I am available. I would love to have a call from you. If you have a question, shoot me an email. And I know that anyone at Cure Duchenne would be more than willing to contact me if you have other questions or need help. So connect with me and connect with each other, because you are living it. You know your child. You know your child. Everybody that is doing it knows what's best for their family. And as practitioners, we're here to help you. Thank you, guys. Sorry, I am not there. I hope you have a wonderful time. Bye.
And the lights are back on.
Oh, here, you do this.
Okay. Oh, there's Rose. So Danny and I are going to get to present together. I'm a physical therapist and she's an occupational therapist. And as you may have found in your experiences, we work together a lot. A lot of things that we do overlap. And so we get to speak together today. Go ahead and introduce yourself.
My name is Danny. And I'm an occupational therapist at Children's Health in Dallas, Texas. I've been working in our neuromuscular clinic for almost 10 years and have a lot of experience with boys with Duchenne, and it's a huge passion now.
Yeah. And my name is Jennifer Wallace. I'm a physical therapist, have been for 20 years, have been working with Duchenne and Becker for 20 years, and happy 20th birthday to Cure Duchenne. All kind of coincides. Yeah, it's been awesome and long 20 years, but I don't know, did I say enough about me? I'm a physical therapist. Oh, I have a private practice outside of Los Angeles. I recognize a lot of your faces. If I met you on Facebook or in person, it's fantastic. If I haven't, please introduce yourself to us before you leave the conference. And then I was going to go into something else. Oh, the topic of our conversation is like the future, like where have we come from in PT and OT and where are we going? And that's perfect because in 20 years, a lot has changed and it's going to keep changing.
Yep.
Oh, I'm doing this.
Yeah, you got the clicker.
Okay. So what have we learned along the way? So I want to start with what overarches everything we're going to talk about right now that we have learned along the way. As our healthcare community has grown, we have learned so much about how many of us are involved in your care. And I think the best part of that and what we've learned is that we all talk to each other now. So hopefully you have a team that will talk to each other and we are figuring things out together. We're not working in silos like we were many years ago.
Right. So we've really learned that being proactive has so many benefits. When I started 10 years ago, I had so many patients that would come into clinic and say, oh yeah, we went to a therapist and they didn't recommend therapy because they said, I have a progressive disease and there's nothing they can do for us. And so hearing that was incredibly frustrating because there is stuff to do, and I'm hearing that so much less now than I did 10 years ago. So it's exciting that that education is getting out there, and there are things that we can be doing for our patients.
Yeah, and for all this time, you've heard us say, oh, you should be doing stretching, you should be doing these things, but we didn't know for sure what that was going to look like later. We intuitively knew it would help, but now after all these years, we are able to see that starting proactively, working on tightness and trying to mitigate fatigue has huge payoffs in the long run. And so we're glad to be able to see all that effort that we've asked you to do is really not in vain. And so one of the primary things that we do see is how much longer somebody might walk if they don't have tight heel cords, if they haven't worn themselves out and have done well conserving energy.
Right. We know that now that early intervention leads to better long-term outcomes. So, for OT, if we're starting early, we are going to work with a kid on being as independent as possible in self-care or at school or, in these play activities or leisure activities. And as those things start to get more challenging, they're able to stay independent for longer because they had those skills early on, instead of having a kid who came in and parents are just saying, you know, it's just easier if I do this. And the child never learns the skill when they have the capability to do that.
Yeah, and that's where our OTs shine in a lot of those skills. And then for PT, when we start early, I'm talking about our young guys who are running around and you know, at school they'll say, we don't notice anything, should we really be doing anything right now? But what we are teaching them even early on that really helps them later is that body awareness. How do I feel? Am I tired? Am I not? You know, just being aware of their own body, which most 5-year-olds aren't, but we're teaching ours to be. Making better activity choices to conserve energy, right? Not like this activity is bad or good, but how do we do this activity differently to make it less damaging? But to make better decisions, even on their own. Cooperating with routines, right? The earlier we start those routines, the better results we have. So it's just like if you told your kid, oh, you don't have to brush your teeth until you're 6 or 7 years old. If you did that with stretching, you would have just as hard of a time. So earlier the better. We've learned that over time.
Right. Really focusing on getting kids to identify when they're fatigued and self-limiting instead of you having to run around behind them and saying, okay, no, you got to take a break, you got to sit down. It's, are you listening to your body? Does your body feel tired? Do you need to sit down for a couple of minutes? Do we need to change this? So,
yeah. And the only other point I thought of right now is part of that earlier intervention is starting to get those power mobility devices in place even at a younger age so that they're using them to conserve energy, to save their energy for the good stuff, like some of the guys will say. So that's one of those earlier interventions that we do for the greater good of the long term.
yeah. So we've also really learned along the way that we have to protect that muscle. Protecting that muscle is imperative to better outcomes later on. Overuse of muscle can really cause damage to the muscle, and when that muscle can't repair itself, then we can't undo that damage.
And I think we talk about overuse of muscle a lot more than we talk about underuse. So if you haven't heard of it, when a muscle is underused, it's prone to atrophy. So you can actually lose muscle and lose a lot of strength from muscle atrophy. So overuse and underuse, we have learned a lot about them over the years, and those can both be an issue.
Yeah, we have to find that sweet spot of, okay, we can do this, but we got to also take breaks. Yeah.
You want me to go on something?
Yep,
Okay, I'll go on. One of the big things that she and I talked about when putting this together is we're not just protecting muscle and preserving muscle for the sake of doing it, for the sake of longer walking and things like that. But as you heard all day yesterday, many of these drugs that are in the pipeline that were coming to fruition, that are coming so soon, you'll notice that we'll probably get better results from being on those treatments with the more muscle that you have viable to treat from a lot of those treatments.
Yeah. So we've also learned that there's different types of exercise that might be safe and beneficial. So there's really some good studies that are being done. Some are already published, some are in the works, that really help us understand what exercises are safe for what stage of the disease. And so we know that exercise overall is very beneficial, but working with therapy to find out what's going to be safe.
Yeah, and that research was so important. It's starting to come out. It's not complete. There's a lot of work to be done in exercise. But that's one of the primary questions I get from you all or your therapists when they contact me is, what exercises can we do? And for a long time, we just said, we don't know, or don't do it, or something like that. And we're kind of getting to the point where we can say, in this stage of Duchenne, these exercises might be appropriate. And in this stages, it's not. So we are much more close to that, and very thankful for the research that has been done to help us with that.
We know that exercise is important for managing muscle, keeping muscle active and preventing that atrophy, but we also know that it's extremely beneficial for that pulmonary and cardiac health. So it's really important to make sure that that is happening.
Yeah. And our last point on this slide is about flexibility, which most of the time is the first thing you think of when you hear at least physical therapy for Duchenne is, oh, we have to do stretches, right? And we will harp on it. We will talk about it a lot. It is advantageous. We have learned over the years how important it is. And we keep saying that deterring joint contractures from the start is important for managing prolonged function, mitigating some pain symptoms, things like that. So you'll continue to hear us talk about it, and I'm not just talking about stretching, we're talking about splinting or serial casting, even the use of standers. Those are types of and ways that we help manage flexibility.
We also have learned, kind of prior thoughts have been, range of motion for the upper extremities has stayed pretty stable until you lose ambulation, and then that's when you really start to get tight. But we really are learning that that tightness in the upper extremities, the arms, the hands, can start kicking in before loss of ambulation. So making sure that we're proactive in that and managing that flexibility. So.
All right, so that's what we've learned along the way. This is sort of where we're at right now, which we got to talk about a lot of these points because that's where it got us to.
Yep. So we have our preventative strategies. We want to lessen muscle damage and overuse, so we use energy conservation. We're going to modify daily activities and preferred social or fun activities so that our boys can continue safe participation in those activities.
Yeah. And then you see the words again, atrophy. So that's that word that I just mentioned about not using your muscles enough. And this is mainly true for those who are having difficulty walking, so they're not walking very much, not spending much time, still ambulatory, but not spending much time. So there might be some atrophy in the muscles that are not being used. Somebody who's become non-ambulatory, not just the legs, but the arms can atrophy too, because once you're non-ambulatory, if you're sitting in a chair most of the day, you don't use your arms as much as you used to either. So we use strategies to try to prevent that atrophy.
And then we really want to work on deterring joint contractures, as we talked about earlier, so that our individuals with DMD can continue to wear shoes, they can continue to use their hands for school or typing or playing video games, which is the biggest, most important thing for our boys. And then once that contracture really sets in, it's hard to reverse. And so as we mentioned earlier, looking towards the future with these therapies, if that contracture is there and then we have some sort of disease-modifying treatment, it's hard to reverse that contracture.
And the last point there says safety training, and I'm sitting here looking at you all while I was thinking about the bullet point, and I noticed at least 10 occurrences of fractures that I know of that are sitting in a close proximity to me. Safety is very important, especially now that we're getting these guys, a lot of them, to walk longer. But are we being safe? Is the environment safe? What is the fall risk? And us as the therapists, we can help you identify what risks you have for fall to try to prevent fractures and what to do when they do happen. But I'm not just talking about the guys who may fall and may have injuries, I'm talking about you too. So transfers. For your safety and theirs, we do a lot of transfer training for your safety and theirs, because if you're injured, then you can't transfer them anymore. And actually, there is a study, it's a little bit older now, but there is a study that shows that most of the fractures in Duchenne were happening during transfers. So, oops, I tripped over the footrest, or we didn't make it all the way to the bed, or a spinal fracture just from twisting or landing too hard, things like that. So lots of safety training you should expect from your therapists.
And then we also look at treatment strategies. So we really want to maximize independence with daily living. So we're going to analyze the home environment, the school environment, work, if you're out in the community, to meet those needs of that person. So that could be making recommendations for home renovation. It could be identifying how to create your work setup to make sure that you're using the least amount of energy or you are safe in your environment, all of those kinds of things. Yeah.
And I like to talk about equipment and assistive technology. I'm not very techy, but I love how far along the field is coming, and there's a lot of interest in engineering, biomechanical engineering, robotic engineering, and those things are transferring over to be assistive devices, which I think we've got Austin here that's going to help us with maybe some of that, but the equipment too. We get very involved in not just recommending the appropriate, but making sure it fits and functions correctly. So that's definitely something that you might get from your therapist. The next point is rehabilitating after a fracture, which I started to get on my soapbox a minute ago. It's not just about safety, trying to prevent those fractures, but they happen. Even when we're trying to prevent them, they still happen sometimes. So helping rehabilitate, which is a newer thing for us. 20 years ago, we thought if you fractured your femur that you would never walk again, and that's not always true. It's in my situation, just in the last couple of years, we've had so many that have rehabilitated after a fracture. So really look to your therapist to get you through that. And we're also working with the orthopedic surgeon community to make sure that we have a strict guidelines of what to do in these situations.
And then looking at behavior and cognitive interventions for our kids that need that. You know, they need school accommodations or treatment for executive functioning or sensory strategies. They have sensory processing issues.
Yeah. So use us OT and PT a lot. Where are we going from here? It's going to be a wild world because things are changing.
Yes, it's going to be, therapy interventions are going to be a lot more varied because every patient's going to look different. You know, no one person is the same as it is, but then you're looking at, you know, different ages and different stages, getting different levels of treatment, and
Different
what is
kinds
that
of
going to look like?
treatment.
And different kinds of treatment.
Like, is it affecting the muscle, or are we going gene therapy? What's going on? So your therapists are really going to have to keep updated and look to us to try to do that, because we will be updating as often as we can. But give us some time too, because for these first couple of years, as new treatments are being FDA approved, hopefully, and all, we're also going to be watching, observing, recording, trying to figure out what's happening in this scenario versus that scenario. And then rewriting our standards of care, rewriting our standardized testing and interventions for these couple of years. So it might be a little tricky, actually. It's a good kind of tricky to have, but it might get a little tricky, as we've seen with the SMA community. Yeah. Once they got their profound treatments, we've seen how tricky it's been for them as well. One of those ideals that we were talking about is if there is a treatment, let's say, that helps preserve muscle longer, then maybe the guys are going to walk longer, even if we don't manage every single activity. We don't have to worry about conserving energy at such a young age, and so often those things might happen. So we may change the way we speak about things as these come along, but we're learning right along you.
Yeah, I mean, we're really, I think the goal, as was discussed earlier in the conference, is doing these newborn screenings and identifying patients who could potentially get gene therapy and have a completely different trajectory of the disease. And so what is it going to look like with these patients who are pre-symptomatic and receive the medication, and, you know, what is going to be our role? So I think it's exciting.
And most of you know that we teach a lot of other physical and occupational therapists how to treat Duchenne, because we need to get these clinics, everybody up to par on that. But a lot of our attendees are pediatric physical therapists, pediatric occupational therapists, school physical therapists. But we have to get our education into the adult clinics. We already need it there. So many of our adults with Duchenne can't find somewhere to go. So that's going to be even more of a mission of ours, is to we got to get out of the pediatric field, and we have to get into the adult clinics as well, so they know what to do in this new DMD world.
Yeah. Therapy is going to likely include new exercises, new home routines, and the team really is going to need to communicate more effectively. So the team is going to be the families with DMD, the patient, the therapist, the doctors, the pharmacists, the advocacy groups, you know,
the whole team,
social worker, everybody.
But the team will have, like, I may notice something, they may notice something, and if we're not all talking and continuing to talk, then a lot of this new information that's going to start happening is going to go unnoticed, and we don't want that to happen. And also we were thinking too, like, our communication with the pharmaceutical companies, like, hey, we're seeing this, is going to be very important. And also, like, Cure Duchenne's link, the integrated biobank, I think I got the right terminology that we like to use with it, is going to be so important for me to report, for you to report, for everybody to report back, so that the new information we're getting becomes something quicker, instead of like, you know something and they know something. Like, we got to get it all together and communicate with each other. So, and we've run way over time, so yeah. But next up, yeah.
I could keep listening to them forever. I always learn something new every time I get to listen to them speak, especially from the different but yet similar perspectives sometimes in PT and OT. My name is Austin Edenfield. I'm a ATP and SMS, that's an assistive technology professional and seating and mobility specialist. I also have my master's degree in assistive technology studies and human services. And what we're going to be talking about today is just various things to consider, and we're going to be going over what an ATP is, what an ATP does, different ways for you to interact with them at a clinic perspective, or even when they're delivering equipment to your home, different things to consider for you guys so you know kind of what to ask for, different considerations that can be made to help your kiddos with DMD be as independent optimally as possible. So what does ATP stand for? Is it any one of these things? It actually is all of these things up here that I'm not going to try to pronounce. But in my case, it's an assistive technology professional. So what an assistive technology professional is it's someone that has gotten a certification. So if we remember the song ABC, 1, 2, 3, it's alphabet soup today. I'm going to hit you with a lot of acronyms. ATP, Assistive Technology Professional, it's a certification that you get. It's provided by RESNA, which, get this mouthful, Rehabilitation, Engineering, and Assistive Technology Society of North America. Say that 5 times fast. So basically, RESNA is an organization of rehab engineers, scientists that come together to make standards, and they use these standards in conjunction with FDA and the other group as far as benchmarks or guideposts on how future assistive technology is developed. So the ATP certification means you've completed training on how to properly evaluate someone alongside a therapeutic or clinical team, as well as how to do assessments properly, how to look at the evidence-based practice, and then how to properly adjust and fit equipment, whether it's for postural asymmetries or abnormalities. All right, here's why an ATP can be important. According to CMS is the Centers for Medicare and Medicaid Services. They oversee the largest financial aspect of our government with a $1 trillion budget. They have a rule that says if you're going to deliver power wheelchairs or sell them, you must have at least one person on your staff that has the ATP credential. Here's a definition I actually took from CMS, I believe. An ATP is a service provider who analyzes the needs of individuals with disabilities, assists in the selection of appropriate equipment, and trains the consumer on how to properly utilize said equipment. So that's really what we do in a nutshell as ATPs. So as far as expanding on that nutshell, cracking open the nut, what does an ATP do? Well, we all love, in the Duchenne community, to play video games. My favorite is RPGs, so you always have a mage that does magic in your party. You have a fighter that's typically a physical bruiser. You have a guide that guides you, or just a general support person. It's usually the person that heals people in your party. So my self-deprecating self says I do none of that, but sometimes I feel like I get to participate in your journeys just enough to do some of that. So really what we do as ATPs is we work alongside the PTs and OTs in a team-based approach as the OT or PT is leading that assessment of that individual, calling out their symptoms, looking at their range of motion, their flexion, their extension, whether we have tight hamstrings, how weight-bearing we can be, etc. And we're looking at how someone presents and what equipment is available that can assist them in being as independent as possible. So what I'll typically do with my clinics is I'll bring in multiple different devices. If I'm working with a therapist and maybe the kiddo we're working with is starting to lose control of some of the distal phalanges, the fingertips, we'll look at different alternative drive controls that we can equip on a chair to drive it. We have an example at the booth there of a head array where someone can use their head to control proximity switches to not only drive their chair but also control an iPad. And we have that iPad also hooked up to the television out there so they can actually control the TV as well. So the ATP helps with fitting everything in the equipment. Fitting is everything. If the equipment doesn't fit, you can slide out of it. It can lead to injury. It's not going to help you maintain what we would call a functional posture, enabling you to be as optimally independent. And so we help with the fitting. We help with bringing equipment to evaluations, putting clients in the chair, making sure that they can operate it safely, that all the cognitive faculties are there as well as the physical faculties. And then we also typically will do a home assessment to make sure that the doorways, it can fit through the doorways, that the seat to floor height is going to be low enough to fit that chair underneath all the tables in the house, that if we're looking at some sort of powered assist system for transfers like an anterior tilt that will gradually extend you forward to help kind of dump you out of the chair or help you reach for objects, that we're measuring the height of different cabinets, the depth of different cabinets. We're looking at your commode situation, how are you transferring. All those situations factor into what type of drive wheel recommendation I'm going to make on, where we're going to look at placing the center of gravity in that chair, what type of postural supports we're going to have to aid in, respiratory functions as well as digestion, all sorts of things. So we also will deliver the chair and provide education and training at that. Basically a liaison to independence, that's kind of what we do. Again, we are a partner of the clinical team. I am not a PT or an OT, I am a no-T. So I am not a certified physical therapist or occupational therapist, so we kind of work as a team. The job of the therapist is going to be to lead that assessment, and I'm kind of like a sounding board during the assessment, like, hey, I have this, or we could try to make this adjustment to get them more comfortable or increase sitting tolerance. And then what the PT or OT will typically do as well is they'll write a letter of medical necessity to the insurance justifying why we picked what we picked, why we rolled out the least costly alternatives, and that why this is the ultimate equipment for this person and why it should be funded. Example time, I kind of already did that, but a typical evaluation for me will be, I like to work with my clients to do a home assessment before we go to the clinic to do an eval, so I'll try to load up a couple chairs in my van because I don't know what's going to be the best because we haven't done the assessment yet, right? We haven't seen all the evidence, we haven't put the kiddo on the mat table and taken a look and put our hands on the hips and everything, so I try to bring multiple things in the home. I take measurements of how high the light switches are, again, how high our tables are from the floor. I take the tub measurements because one of the things we provide as well as ATPs is like bent metal or bath equipment, shower equipment. So I'm looking at in the home, like, do we need a transfer system to transfer like a sliding base system that slides from the commode into the tub? Do we need something more like general and PVC with netting? Like, what are we really looking at? Do we need something really tight and confined with a really narrow base because we have, 35-inch hallways? Or what kind of things do we need to have in the home? Is it in a rural area? Do we have a gravel driveway? And I like to bring the family in on that and try to answer their questions and kind of interview the family while I'm at the home. Tell me about your son. What does he do? What does he like to do? What's his routine? When does he get up? When does he go to school? Like, when do we do feeding? When do we do bathing? When do we do grooming? How do you guys transfer him? Where do you transfer him to? Is it to an uneven height bed that may be higher or lower? All of that kind of plays into what we're looking at when we're speccing out a chair as far as seat to floor heights and measurements. Then I'll come with you to the clinic. I'll work with the clinical staff. They'll typically do, my clinicians who are my favorites will do a mat assessment, where they kind of bust out the goniometer. It's an angle measuring tool, and we'll measure flexion, extension of the hips. We can kind of palpate the ischial tuberosities and see if we have like a pelvic obliquity or a pelvic rotation going on, something that we maybe can adjust with a specialized cushion or even a mold. We typically don't do molds with DMD too often until they're older, but that's kind of an example of what we would do at the eval. And then as the parents, you guys would say, hey, out of all the things, I'll say, based on how your child is presenting, based on the recommendations of the therapist, chair X, Y, and Z, I think would be the best options for you. Maybe we'll bring them by your house for you to try for several hours or come pick them up the next day. And you guys will kind of let me know as the supplier which one you want to go with. That is like a dream assessment in my world. And then we'll write it up. They'll get me the documentation. They'll send it. We'll get the prescription from the doctor. My funding team or whatever vendor you're working with funding team will submit that to insurance. A fast turnaround time is going to be 45 to 50 days, depending on your payer source. A lot of payer sources do like to just deny things outright to see how bad you want it and how much you're going to fight for it. If we have to do appeal after appeal and I end up taking them to the ALJ, that can sometimes prolong things many, many months. We've delivered equipment 9 or 10 months sometimes after that evaluation if we have to consistently fight the payer source or insurance to cover basic things, or if we have to keep adding addendums to the letters of medical necessity. So what do you need to know as far as when you're going in to work with a supplier and you're going in for an eval? The most important thing you need to know is you have all the power. You don't work for them. We work for you, okay? Some of us ATPs can be a little bit salesy, and sometimes some of us ATPs can be a little bit pushy. And if you are feeling that way in the interaction or in the evaluation, you're in control and you can tell them to take a step back. If they're not doing what you want, they're not treating you with respect, they're not letting you trial different pieces of equipment that you're wanting to see, you can work with another vendor. If you go into a clinic, oftentimes clinics will say, hey, we have a great relationship with vendor X or vendor Y. Do you want to use them? You can use who they suggest. Most clinics will just give you a list of different ones they work with. Or if you have a vendor you really like that you've been working with your kiddo with DMD for a long time, you can say, actually, I want to use my own vendor and I want to bring them to the eval. So you have all the power. Ask other families what they use. You don't know what you don't know. Talk to other families who have kids with Duchenne about what they use, how they use it, what they like, and what they dislike. Take notes. Write a little note in Google Keep, or even bring a sheet of paper into the eval. Ask questions, because when the eval is underway, it's quick. My longer evals are about an hour and a half. Generally, unfortunately, I would say that tends to be uncommon, and they're usually shorter. A lot of my therapists sometimes will do a second eval, but oftentimes you typically may be working with an hour or less, so it's tough to remember things. Bullet-pointed questions go a long way in your eval. Again, I've presented a few times in the past couple years at this conference. You can go back and watch those. We have QR codes at the table in there on various forms of assistive technology that you can scan to get you some great information as far as different ideas to talk for, things to ask for. If you're not sure, come talk to me. I'll be in the booth. I'll be walking around. I'm happy to give you my email. I live in Nashville, so my branch is based in Nashville. So if you're not based there, that's totally cool. I would still love to help you for free and just answer any questions you may have about processes. And if you want to see or trial something, you're at a support group and someone with DMD had this really cool feature on their chair, ask about it. They work for you. A power wheelchair costs a lot of money and gets a pretty good amount of commission for some ATPs. They will do what you ask if they're a good ATP, and if they're not doing what you ask and they're not showing you what you want to see, go with someone else. Don't sign for equipment unless you're fully satisfied. If you're at the eval and we're showing you options and we're all on the same page with the therapist, with you guys as clients, and we show up at your house with a completely different chair, a completely different seating system that was not at all what we discussed, we have to have you sign it. Sign that you received the delivery. You can refuse delivery. Again, we work for you. You don't work for us. So you have the right to refuse delivery if it's something different, or there's a surprise that you didn't see coming, or something completely different shows up and we failed to communicate, oh yeah, that chair was discontinued, or the lead time on that part was 8 months, so we know your kid needs this now, so we went with this. You can refuse delivery. You totally can. We really don't like that when delivery is refused, so that puts the onus on us as ATPs to be, more effective communicators. Call us. Call them after the eval. Hey, I was online and I saw this other thing and we didn't get a chance in the eval to talk about that. Is that something you think, something you think would be necessary? Sure. Or call your therapist with questions. There's a lot of accessories out there as well that aren't typically covered by insurance that can be incredibly useful, like backup cameras or certain harnesses, etc. So to close, I got to ask these two questions. As we look forward to potential approvals for transformative therapies, how do we assure that the assistive technology and equipment plays a role in both the extension of life and the quality of life? And I've got a couple points on this. Number one, exercise your civic duty. It doesn't matter whether you're Republican, Democrat, or Independent. Who we elect into office directly plays a role on the funding we receive at the state level and the federal level. Case in point, right now Medicare is considering for the first time ever covering power seat elevation and power standing. There was a comment period that most people didn't know about where anyone that was a clinician, an ATP, a parent could write comments to CMS on why this should be approved and what their kids use it for and how it's life-changing technology. That would obviously help sway, the answer in our favor to where this would be covered technology and it wouldn't be thousands and thousands of dollars out of pocket. Politicians play a direct role in this. Exercise your civic duty, vote for what's important to you and what matters. Advocate for change. Here's one organization of many, NCART, there's their thing there. So they are kind of galvanizing and leading the fight for coverage of power standing, power seat elevation, and things of that nature. You can subscribe to the newsletter. It's free. It's got some great information on there. Speak with your dollar. As we look at companies around the world and accessibility becoming more and more commonplace, if there's one company that makes an accessible voice assistant, speak with your money and buy that one, versus one that maybe doesn't have accessibility features or may be harder for someone with neuromuscular condition to use. An example would be one major technology company just laid off a lot of their assistive technology division. So things that used to be standard with their products, such as the ability to use an eye tracker natively in their operating system, are no longer there. That affects a lot of the populations I work with from being able to use a computer. So just things like that. So now when I have my money to buy other technology, I'm looking at what else is out there. So those couple things. How can we prepare people with Duchenne for a future where they're an active part of society? Stay up to date. You can create Google alerts for assistive technology. I get alerted daily on all sorts of new technology that's being made overseas or all sorts of new clinical trials here in the United States. You get a nice, compact newsletter in your email every day. Use other people, check YouTube, check TikTok. TikTok is for these young kids. I'm not even on it, my wife is on it, but I use her phone to look at TikTok because there's all sorts of just, new ways to use a straw, new ways to use utensils, new ways to think about things on TikTok from people with disabilities that I'm learning from every day. YouTube channels are also great. A lot of commonplace things we have, like Alexa or a Google Assistant in the house, or an iPad, they already have so many accessibility features baked in that people with DMD can utilize and that would help them be productive and have a higher quality of life. We just don't know how to use it. So consult, go to apple.com or look at YouTube, or even just spend some time playing with your own devices. And then teach the importance of the last 3 items. Oops, I'm going like, I don't know what I'm doing. Leslie, help. Wait, here we go. Thank you, guys.
It just turned you off.
I said, let's party. That's all I saw.
Is that us? Are we done?
Yes.
He went to the party tonight. He went all the way to the party.
All
That's
the way to
great.
the party.
Party.
We do. You guys, thank you all. I mean, Grant came back there and visited with me a little bit. There's like a VIP room back there where you could watch. So I watched the whole thing. It was really great. And we do have a few minutes that we can do a few questions if there are some questions. One's already ready. Good job.
Hey, thanks. I got this from Dr. Edwards, because you mentioned inviting you to be a member of the IEP. And I had never really thought about inviting a urologist to an IEP before. And then I was thinking, the same for the OT, the ATP, the PT. I mean, you guys could be valuable members. When would you suggest parents with children with Duchenne invite you in and to consult?
I think, I guess I can take that. I do it very often for families, and a lot of times we're not at the meeting, I guess, at school or potentially with the school nurse, unless a child's doing a clean intermittent catheterization program or has a different anatomy to their urinary system. Those children have very complex needs, but we're there, and I think a lot of times people don't think about needing that assistance and documentation for toileting for their child, and then also troubleshooting with privacy concerns. So some, as kids get older, young adults, they want their privacy, they want to be able to use the restroom, and figuring out ways to facilitate that, to give privacy. There's a lot of tips and tricks we can do, and so a urologist, at least I do, I provide documentation for all of my families that see me. I find out what the need is, and then for some reason, sometimes it depends on the school system and the school, but if we get any pushback, I just send a letter as a surgeon and say, this child has this concern, this is what we need, and I have not had anybody turn me down yet. So we're happy to support for hydration, for urine and stool, anything we can do.
Well, and from my experience, we don't have urology really as a part of our multidisciplinary clinic, and yet we still need that. And I think your presentation highlights how many of us are struggling with some of these things that we're just handling and managing on our own, and that there are solutions out there. So I hope that we'll take advantage of that.
Hello. You actually just hit on my question. There's a lot of specialties that aren't part of the multidisciplinary clinics. I know for like pediatric endocrinology, GI, how do you suggest that they get like the same type of information that you're providing to help our kids when they see these physicians?
So I hope I can definitely speak just because I'm a pediatric urologist. At most large pediatric hospitals in the country, there's going to be a urologist that's specialized and very comfortable with neurogenic bowel and bladder, because that is a huge patient population and why a lot of us chose pediatric urology. And so I think for the Duchenne's community, we're there. I just don't think people think of us. And how I got involved with Duchenne's muscular dystrophy, I have some patients for sure, but I didn't really I didn't know this existed. This is wonderful, and it's been a great experience for myself. But Dr. Matthews is our neuromuscular physician at University of Iowa, and she approached me and said, you know, what do you think about this? And I started with spinal muscular atrophy and have done some research there, and then I gave a talk with, you know, PPMD in the fall, and after that I realized how little is out there for urology and how big the need is. And so I'm hopeful, and that's why I made the survey for toilet training, because it's kind of heartbreaking to talk to families, and they were like, well, why is this a struggle? And I was like, you know, we don't have it, and so I want to help, you know, facilitate that. And I know that there's other urologists other than myself. That talk I gave in the fall was with 2 other pediatric urologists. One was my partner, one is at University of Colorado.
That's great. So, I mean, but that's something, I guess, that knowing this, we can use this information and we can try to advocate for ourselves for that. But I do think, I mean, it's something we're going to utilize now, certainly. Yeah. Okay. Run, Doug, run. Here he comes.
Go, Doug.
So they were talking earlier about recommended cardiac MRIs with gadolinium, and I looked it up really quick, and it seems like the only thing that gadolinium hurts is the kidneys.
Yes.
Is a child who's got a history of kidney stones, should they avoid?
It depends on what their glomerular filtration rate, so their kidney overall function. So gadolinium can be a safe tracer if someone has preserved kidney function. MRI is not the best test for trying to find a kidney stone. It's actually a little bit harder to see on MRI, and so we use ultrasound in the pediatric population, and then of course CT scan is the main diagnostic tool for, but much like it was mentioned by the cardiology faculty, that the dye for CAT scan is a little bit more toxic to the kidneys and can cause an acute kidney injury, more so than the gadolinium, unless somebody has end-stage renal disease. So if somebody has more significant kidney disease, they do need to talk to their nephrologist, their urologist prior to getting a contrasted study. Okay. But there's thresholds that we watch. And anyone that's getting these testing, much like they brought up at your 6 month, everybody's getting their kidney function checked. And then in children, sometimes creatinine's not the best marker because of the muscle turnover. And so the cystatin C is a more sensitive, so we're starting to use that more often in children for our marker for kidney function.
Okay, thank you.
You're welcome.
I have another question for Jennifer. Are there any papers yet about how well the kids who were tested on microdystrophin, if their physical therapy needs have changed?
Not that I know of. Yeah, just I'll give you the cut and dry answer, not that I know of, but that's the kind of information that we need to start gathering and training other therapists on what to expect if they're on a dystrophin producing drug, if they're on a muscle preserving drug, if they're on an alternative steroid, those types of things. We need to know what to expect so we can treat our patients individually.
We've got time for another one if there is another one. Oh, Mr. Doug Levine, of course.
Yes. So it's mostly for Austin. So many of the families go to, every 4 months or 6 months, go to a multidisciplinary clinic of some sort. So there's, usually a urologist, physical therapist. A lot of times there's an ATP that's representing a certain company. And so the ATP will visit with the family there. Does that necessarily mean that that family has to use that company that is in clinic, or are they free to choose any company that's out there?
They can use anyone they want. If you've been in this, the saying is, if you've been in one clinic, you've been in one clinic, because they're all so different. A lot of clinics have vendor rotations, so for one quarter they'll use, one vendor, for another quarter they'll use another, and they try to be, fair like that. Whoever is in the clinic on that day, if you've had a bad experience with that company, you don't have to use them. And actually, it's completely unethical for a hospital or clinic to push a specific vendor on you, and that is actually can go into the illegal boundaries. So no, if you have a vendor you like and they're not represented at the clinic that day, just speak up and say, hey, I already have a vendor and this is who I want to work with.
And I like how Austin, I think, has given me some more knowledge, and I think is giving us some more language on. I didn't know that this was really an area that we also needed to advocate on. I feel pretty comfortable knowing that I need to advocate for certain care, but equipment was one of those things that I thought we'll just leave it to the experts. So I really appreciate you giving us some of the language and some of the landscape on how we can make sure that we're getting our kids what exactly they need and what we want. So is there any more? Maybe one more, or are we done? Oh, yeah.
Just to follow up to both of you, so
Yeah.
how do we, if the clinic that we go to now does not have an ADP, is there an independent ADP company that one could go and reach out to that's not tied to a vendor?
Generally, no. An ATP is just a certification, so there's OTs and PTs with that certification. A supplier, in order to sell you the type of complex power chairs or even manual wheelchairs that kids with or people with Duchenne use, they have to have an ATP on staff. And I think the majority of the 50 states, that's a law. So if your clinic doesn't have a vendor that they work with, or most clinics will just give you a list and say, here's who we work with, and you kind of pick from the list. Ask around. Ask around in your Duchenne support group, hey, who did you use for your wheelchair? Did you like them? You know, what do you think? Is it worth giving them a try? Oh, we love this person. We've used them ever since little Johnny was 5, and now he's 20, and he's been great and well taken care of. So that's a good way you can do, or just use Google. I'm with Reliable Medical, but us and our competitors all have websites where you can put in your zip code, and it'll locate the nearest branch to you, and you can call. Did that answer that?
I think that's great.
Okay, thank you.
Yeah, and so we really appreciate this panel. This is great. Now, after this, it's time for us to kind of leave. There are some people that are going to be